I'm Judy Maxey, your hostess for today, and we're so happy to have you join us. Our topic for today is health complications and issues during COVID. And so we hope that you will learn much today and be able to assist yourself and your loved ones with the information that our panel will share. Before we begin, I would like to read our disclaimer statement to you. The content in this program is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified health provider with any questions you may have regarding medical conditions. Also, we would like to ask for those who are in the chat, if you could limit your comments and questions to the topic of today. And also we ask that you would refrain from putting advertisements and other opinions on the chat. That will make it easier for us to cipher out the questions that are relevant for our speakers. Thank you. And now I turn the program over to Dr. Randall Maxey.
Good afternoon, everyone. Welcome to this informational call. I'd like to introduce our guest speakers for today. They are in order of appearance. There will be Dr. Ann Stavern, who is a noted pediatrician, allergist, and immunologist practicing in the Los Angeles area, former president of the Charles R. Drew Medical Society. And she is, I always tell people she was my kid's physician. I'm very grateful to her. Our next speaker is Dr. Janice Lee. Dr. Janice Lee is professor of medicine at Emory University in Atlanta, Georgia. She has been the principal investigator in a number of landmark studies concerning high blood pressure. She's a nephrologist like I am. And I tell people she reminds me of Alicia Keys, but she is a noted academician within the physician community. Somewhere around 60 years ago, I was getting interviewed to do my internship at Harvard, and the person who interviewed me was Dr. Wilbert Jordan. So he's older than me, note that in your book. He is a world-renowned authority in infectious disease. He concentrates on HIV, which has some relevance to our discussion today. Dr. Wilbert Jordan is a professor of medicine at Drew University and has been a long-term expert. I put him on the level that some people put Dr. Fauci on, but Dr. Jordan always tells the truth. We have a special guest that will come on shortly after 1 o'clock. I'm going to save his name and who he is until the time I introduce him, and he will give a brief statement. So our format is each medical speaker will speak between 5 and 7 minutes. They will share their screen if they have slides, and we'll try to get through all the presentations and then let them be a panel to answer questions. I always start this with a view, my view. If you are around or see anybody at your workplace, in the street, near your family, your children or you, and they're not wearing a mask, consider them your enemy. The infection rate, the case fatality rate and the death rate in this country are going up. I've heard stories of young people having parties and they make a bet, and the person who gets infected first as a result of that party gets paid money. There's a lot of stupidness going on, and we can't stand that because our communities and people are at more risk than others. And we tend to get infected at a higher rate. The death rate is higher in some communities where we make up less than 15 to 20% of the population. The infection rate is more than 50 to 70% against us. So I'm very concerned that we don't fall prey to other people's indiscretion. We know that masks are important. The mask does not protect you when you wear it, it protects those that you are exposed to. We know that when you talk, when you sing, that there are droplet spray that leave your mouth and nose, and it can infect other people. So it's strong words, but I think if somebody comes around me at my senior age status and they don't have a mask, I consider it attempted murder. I will not allow them in the room with me, and you shouldn't either. Now, a lot of people will wear a mask around their mouth and leave their nose open, insist that it cover their nose and their mouth. I know that you're tired of hearing it, but you must wash your hands. Every time you think about it, you should wash your hands with plain soap and water. After that, you can use alcohol 60% or any other hand sanitizer that's agreeable to you. But soap and water is the single best thing you can do. Wear a mask. Keep your hands out of your eyes, out of your mouth, out of any place that this infection can get in. It is dangerous. It is not limited to seniors, even though seniors, those of us who are over 60, it's just that it tends to affect us in a worse way. We tend to have more deaths in that age group. But make no mistake that in every age group, whether you're 50, 40, or 30, or even in the 20s, they are experiencing severe illness and they are experiencing death. There was even a rumor going on early that Black people were less susceptible to the disease. That is not true. We're all susceptible. You should look out for the signs. The signs can be an elevated temperature. I'll let the infectious disease people talk about that. There could be a cough, recent loss of taste or smell, cough, other symptoms including shortness of breath. We recommend that people utilize mouthwash such as Listerine or hydrogen peroxide to gargle every morning, because the COVID gets into the so-called ACE2 receptor, and many of those receptors are located at the back of the nasopharynx, the back of your throat. And by gargling every morning, that helps clean that up. We also recommended that you stay well hydrated. There is no current cure or treatment. However, we do recommend that you eat well, eat micronutrients, and take other things that can boost your immune system, such as I take prenatal vitamins, for example, because they have all the micronutrients. I take vitamin C, 2,000 milligrams a day. Some recommend 50,000 units of vitamin D once a week. I'm going to let Dr. Lee comment on that, as she is a nephrologist and an expert with parathyroid hormone and calcium and vitamin D. So it is very important. There are other issues that affect our community. A recent article stated that 10% or more than 29,000 families every day don't know where their next meal is going to come from. There are food shortages. So we recommended in our earlier calls that you maintain a store of food that's, whether it's dehydrated or frozen, enough for several months in your house. Not to hoard food, but to have enough. Some people are growing gardens. So we don't know how long this is going to last. And lastly, we know that there is a push to open schools. And someone sent me an unvetted article this morning that suggested that some people are making a priority to get Black kids back in school first. Now, there's some debate around that. We know kids do better in school. We know emotionally it's good, academically it's good. But we also know that we don't want to send them into harm's way. So those will be some of the questions that we're going to ask our speakers as we go forward. And lastly, I want to reemphasize what Ifeanyi said. We want the chat room to be used for questions that we can refer to the selected delegated speakers and not being blown up with a lot of chatter. Therefore, it's for questions. So if you would respect that, I would appreciate that. Having said that, is Dr. Ann Sayburn on? Dr. Ann Sayburn? If not,
I was trying to unmute. Are you? Am I unmuted?
you're unmuted, Dr. Sayburn, my hero.
All righty, very good.
Let me introduce you again. Dr. Sayburn is a pediatrician, allergist, immunologist, and she is president of the Charles R. Drew Medical Society here in the Los Angeles area, the single largest chapter of the NMA. As I mentioned before, she's my family's personal physician, and given my age, she's my pediatrician too. Dr. Sayburn.
Good morning, everyone. Boy, I guess we already are in the cauldron this morning because this issue for the last 24, 48 hours has come to a head regarding opening of the schools. And I want to preface this conversation by saying it's going to be all hands on deck for the Black community, Black and brown communities. We have to come to an understanding and an agreement between teachers, children, parents, physicians, the public health society about how we are going to open the schools and when we should open the schools. I don't think it will work if the parents don't buy in. It's not going to work if the teachers don't buy in. And it's not going to work if it's still a public health emergency with regards to the public health recommendations. So where are we? Well, of course, as you know, LA County particularly is spiking with the number of cases. School was supposed to be open in person August 18th. That's been thrown into a bit of chaos. My understanding is that they will open August 18th, but it does not mean it will be in person. In fact, I think some of you heard on the news that the superintendent or the board said, from their point of view, it would be virtual online schooling. The question is for our children, what is going to be the best academic approach and the safest approach, knowing that we die disproportionately with this particular COVID-19 infection? These are all questions. It's going to be a definite discussion. I don't have all the answers. I just want to give a little background. Initially, there would be a hybrid of virtual learning and some children would be in schools, and then there would be some staggering or certain days, like 3 days out of the week or 4 days out of the week, because you cannot have social distancing with the number of kids that they have in the school population. They were going to enforce hand washing. All children over 2 years of age were going to wear masks. We're not recommending masks or under 2. They were not going to have cafeterias. You're going to have to bring lunch, or if they had food at the school, it was going to be prepackaged. Your child was going to stay in a certain cohort with the teacher, and there would not be a commingling of those cohorts. And the CDC had 3 phases: closed, where you went online; local, where only local children in that geographic area; and then a more expanded if children came from outside the geographic area. You will be at low risk at online, more risk if you had small classes with social distancing and masks. And then the highest would be just go back to regular school, normal numbers, no social distancing. This was the DeVos-Trump pushback. They felt that was too onerous. Now, to me, I think that's ridiculous. I'm a little disappointed with the CDC if they do not enforce their guidelines. 1, we know children are at lower risk, even Black children. They are slightly higher with regards to asthma, certain comorbid conditions, but transmission is lower. The illness is milder. However, teachers are at risk. People at home, such as Dr. Maxey and myself, who are older, are at risk if the children come home and are infected, though the transmission rate is low at this time. The schools would have to be daily infected. The ventilation system should be prepared with regards to cleaning and making sure they have a good filtration system. So you can see for certain communities, are we going to have it done? Is it going to be safe? And we have to decide together so we have a unified front to say, yes, our children should go to school. Academically, we don't want them behind. Psychologically, we don't want them to be damaged, but we want them to be safe, and we want them to have the same safety tools and design of the campus as everyone else has. And we have to decide that that's what we want to do. And with our political leaders, our doctors, our parents, our teachers, we have to have the approach. Otherwise, I think we'll be left behind. Thank you very much.
Thank you very much, Dr. Ann. I know that you have an obligation, but before you go, there's some statistics I want to read and have you react to them.
All righty.
As of today, there are 3,236,130 cases in the United States.
Yes.
The total deaths today are 134,572. Now we know that this will skew disproportionately in our side.
Yes.
Besides school,
Yes.
what are some of the cautions that we have to protect our young ones, and the fact that they may be transmittable of disease to those of us who are more senior?
Well, Mandel, we have to go to the basics, which you have outlined, and we have to optimize our multi-generational homes. Grandma's there, auntie's there, grandpa's there. These households have to be keenly aware that children, but let's, I want to be quite specific, probably under 12, they are not the greatest risk. It's after 12. It's going to be these junior high kids, the high school kids. the ones who are feeling that they don't want to be constrained won't wear a mask, won't social distance. This is going to be the group I think we need to focus on in terms of telling them the risk to their parents, their grandparents, their elders, why it's imperative that they practice the 20-second hand washing, they social distance, they wear a mask, we don't commingle plates, drinking glasses. And unfortunately, Maxie, at this point, I feel that if we don't get on top of it, those numbers are just going to get a lot worse. And of course, that means that we'll have greater numbers dying.
So I know with us being not-for-profit, we're not supposed to be overtly political.
Yes.
However, as physicians, we must have an opinion of what is best to protect the people that entrusted their care to us. The whole reason for the Black Health Trust existing. Now, you've addressed the school issue, but I believe there's also a cultural issue that we must be on one sheet of music when it comes to protecting our community. Do you have any thoughts before you have to leave of what we can do as a culture, as a group, even friends and relatives to protect those that we love and care for?
From a political perspective, are you saying, or is it
It would be political, but I don't care.
Well, I think first of all, we should do in a more expanded form what we're doing as physicians and being the vanguard for our people in terms of making sure that we're not being left behind in terms of tools to be safe, first of all, because we are going to be the last in line with regards to protective devices, testing, contact tracing. All of this is paramount in terms of controlling this disease. We have to be in the vanguard. I think we have to lock hands with our political structure to make sure, just like the money, you see the money going outside the community, we've got to make sure that our safety tools, our strategic safety plans are not left behind due to our color or economic status. And I think as physicians, public health workers, politicians, faith-based institutions, we're going to have to build a coalition that would probably rival the civil rights movement in the past in order to go forward and be safe.
And the last question I will ask you, and then I'll ask Judy if there's anything question for you in the chat box. But one of the most controversial things that we've talked about in the past several weeks, that we know that ultimately, in order to come up with a way to stop this virus, there needs to be a vaccine.
Yes.
And there are many questions about vaccines in general.
Yes.
Vaccines, Black people, and political. But as an immunologist,
Yes.
would you comment on vaccines? And what my main concern is that if there is a legitimate, viable vaccine,
Yes.
I want to make sure that we can appropriately evaluate it and not refuse it if, in fact, it can help us. Would you comment?
Yes, thank you very much. Yes, as an allergist, immunologist, and as a pediatrician, I feel that the only way to really get on top of this particular illness in our diverse society, we're not talking about Germany or Copenhagen, a smaller, more uniform population, we will need a vaccine. We will have a vaccine. And if it's proved to be efficacious, and safe, if it mimics or mirrors the safety of the polio, measles, meningitis, flu vaccine, then we need to take it as a people. Very quickly, if anyone gets a chance to read the Washington Post, please read it. In Samoa, they had a 95, 98% vaccination rate. Unfortunately, 2 children died in July 18, 2000, I think it was this year. The nurses mixed it wrong. It was not the vaccine. But anyhow, people stopped taking it. Herd immunity dropped to 30%. It was an emergency for the whole country. They were 300% beyond hospital capacity with dying children. Let's not get it wrong. What was the world before we had these vaccines? Children died. It took them almost in a military manner to get the children and the population base revaccinated so that the children were not dying and the older population were not dying of measles. We've been able to control measles for decades. And that is what we're looking at if there is an effective vaccine. There's an African-American woman who is working on this vaccine at NIH. You should look her up, Kizmia Colbert, and she called out Trump and that administration. And she said, your task force has nothing but white men. She made other comments. I thought she was going to get fired, which essentially said the respirators would not go to Black people if there's a short. I mean, she is politically conscious, but if it's safe, and I'm here, other allergist immunologists are here, Black and brown physicians are here to look at the data, to evaluate the data. I will be the first one. I will take a picture on Facebook of me getting the vaccine if there's a way to do it, if I feel it's safe, because I think this is the only way we can go halfway back to normal. And if you want your children to return to school and any kind of normalcy in the future, they're going to have to get the vaccine.
I understand that the NMA is having a symposium on immunizations and vaccines next month that you and Dr. Lenore are involved in?
I'm not, Dr. Brooks, who's our outgoing president, the pediatrician, I'm not directly involved in it, but our section will also have a session on vaccines. And we're going to push to show people how it works, what exactly the vaccine is. And I know there are concerns about other things that go into the vaccine, but we're going to talk about how it works, how it's made up, why it came up. And the last commentary, and I know Dr. Richard Williams, he lost his life partner, but read his book. Where did the vaccination concept come from? Where did vaccinations come from? A slave gave Jenner the idea with regards to cowpox and smallpox. African people understood that you had to stimulate the immune system in a way to bring protection. So it's not some covert Western European total concept. We do have issues with regard to safety. We have issues with regard to experimentation or not getting the right things before, but overall, they've been lifesavers. And we really, really have to consider a massive move to be vaccinated in proper numbers.
Thank you.
Randall.
Yes.
Randall.
Yes, Dr. Jordan.
Yeah, I just want to add to what Ann said in terms of that slave. That is an old concept that was practiced by voodoo practitioners in Africa in terms of making themselves immune to snake bites. Because basically, how I challenge you as a voodoo priest, I had a snake and you had one, and if my snake bit you and you couldn't survive, that was it. So they learned over time how to develop immunity to mambas and other snakes. So I think that's very true. Everything Ann said, I think is very true. but we have to be involved in it because it's also the easiest way to destroy a people, to give them something that will wipe them out. So we have to make sure that we are involved in a vaccine, in the whole process of it.
I agree with you. I agree with you. Process and evaluation. If we could get that young lady to speak who is developing the vaccine out at NIH, I think we should.
Can you send me her name? I want to see if we can have her on that ID program.
I sure will.
So there's another guy looking for a job now. His name is Fauci. He probably will speak too. He got fired.
Fauci's going to speak, they say, at NMA. He's supposed to. So we'll see what
He's spoken there before.
Yeah.
But he got fired on.
Yeah.
But if you elect Biden, he will get reelected quickly, rehired quickly.
Yeah. Well, thank you very much, Dr. Stavern, and Dr. Jordan, thank you. We're going to move to our next speaker, who is Dr. Janice Lee. Dr. Janice Lee is full professor of medicine at the Emory School of Medicine. She is the director of dialysis there. She has been the principal investigator in a number of major studies concerning the health of African Americans, especially in the area of hypertension and kidney failure. She is a prolific writer, and some months ago, she actually traveled to teach our nephrologists in Puerto Rico some of the things regarding hypertension and the treatment of patients with renal failure. Dr. Janice Lee.
Thank you, Randall. Can everyone hear me okay?
Yes.
Yes. Now, how do I share my screen, or do you have to give me permission? I have a few slides.
We have some people to help you with that, Martin.
He mentioned that I wouldn't have to do anything.
In the lower middle of your screen, you should see an option, like right underneath your picture. It should say share screen, and you click on that and it'll give you all the options once you have your slides up.
Under my picture.
Yeah, right where your screen is down, security participants chat, you'll see share screen. If you click on that, it'll automatically put your screen up.
Right between chat, to the right of the word chat.
So it's at the bottom then. Okay, share screen, I have it. Great. Okay, can everyone see this okay?
Yes.
Let's see if I should make the bigger screen. Okay, great. Thanks, Randall, for having me, and I'm excited to participate in this meeting. I just have it's probably going to be about 10 minutes, Randall, if that's okay, my talk, but I wanted to just review some of the risk factors related to COVID-19, particularly in patients with kidney disease. Pertinent to the discussion we've just had about vaccine, et cetera, I'm going to talk about the need for research in minority populations related to COVID-19 and to make sure that our voices are heard in the process. Actually, if we have time, I wanted to just talk briefly about telehealth because I've been doing a good bit of that in response to the COVID pandemic. This slide is an introductory to sort of frame the crises at the state level. And you can see in red are all the percentages of COVID cases in the respective states. And then in the gray, light gray, is the proportion of African Americans in that particular state. So you can see in most cases, the proportion of African Americans affected by COVID are more than, in some cases, more than double of what their representation is in the population as a whole.
And then this slide just shows some of the reasons for this, especially some of the socio-demographic reasons, as far as African Americans making up a large proportion of the workforce in the food industry, postal workers, public and urban transport, etc. We know that the healthcare system is tremendously burdened and exposed, and they make up, African Americans make up 3 million of the healthcare workers, etc. So these are the issues that we're facing as to the limited ability for these patients or to be properly social distanced. So in reference to patients with kidney disease, that's what I am a nephrologist, and we know that people with diabetes and high blood pressure, as well as heart disease and kidney disease, are some of the higher risk patients for contracting COVID and have complications. What we have also learned from our experiences is that even if you didn't have hypertension or diabetes, African Americans are at high risk of developing acute kidney injury from COVID. So that means when they come in the hospital, they're at high risk of having kidney failure. And again, this is in patients who didn't have kidney failure before. And we also know that getting kidney failure as a result of COVID is one of the strongest predictor of poor outcomes, especially of death. In our population in Atlanta, at Emory, in our Emory system, 70% of our patients that are admitted are African American, and also 70% of those who develop acute kidney injury are African American. And we already know all of the statistics about the higher rates of death in African Americans. So this is a particular problem in addition to all of the other complications. This slide is just something I like to show just to give everyone a flavor for dialysis, and I don't know if anyone in the audience is on dialysis, but we know that diabetes and high blood pressure are the predominant reasons that patients end up on dialysis, or what we call end-stage kidney failure, and need a transplant. And we know that those are disproportionately represented in the African American population. Now, just briefly, I wanted to highlight some of the disparities around dialysis because this is particularly relevant to COVID. So we have patients, the majority of patients in the US that are on dialysis go to the dialysis unit to get dialysis. But we do have a smaller proportion of patients who are on home dialysis. And certainly with the COVID pandemic, we know that patients who are able to properly social distance are the patients who can stay home. And so it's particularly beneficial, in addition to other reasons, that patients do more home dialysis. Well, guess what? In the US, there's almost half of the amount of patients who could do home dialysis that are actually doing it. If you look at this table I have here, the first table is what we call PD, and that's peritoneal dialysis. That's a specific type of home dialysis. And you can see the utilization of this in the US is 11% white, and you can see at the bottom 6% African American. Even Asians and Hispanics have higher utilization of home dialysis. And so this is particularly problematic in the midst of COVID because our dialysis patients are being exposed because they have to get out of their homes 3 days a week to go to the dialysis unit to receive dialysis. They're exposed to transporters, other patients, other medical personnel, etc. So with that background, We know that these patients are particularly vulnerable to the effects of COVID. And we know that if you're on home dialysis, patients are less likely to be exposed. And we need more research and inclusion of African Americans in addressing these barriers that we have as far as proper social distancing. So how do we get more patient engagement, more patient-centered research that addresses patient concerns and includes patients in the design of the study? I have an example. I'll talk briefly about the Patient-Centered Outcomes Research Institute that I have a grant at Emory in dialysis patients and patients with chronic kidney disease. And basically, it centers the study around patients so that they can advocate for themselves and participate in the design of the study. Patient engagement is meaningful involvement of patients, caregivers, clinicians, and other healthcare workers throughout the entire research process, from planning the study to conducting the study, and then spreading the study results. I wanted to just show the particular study that I'm involved with, and it does have an application to COVID. This is where we recruit patients to be ambassadors or mentors to other patients with kidney disease. And we're focusing on how do you cope with a chronic illness and how do you educate for patients to get more education and utilization of home dialysis and also be referred and receive a kidney transplant. And so what we have added since COVID, we've added an initial supplement application to expand this education to focus on COVID-specific information and messaging around how to properly social distance, mitigation strategies, and also about the vaccines. I mean, we had a discussion earlier about that. Even in dialysis patients and African Americans, there's a lower utilization of receiving vaccines. And we know that this is going to be an important issue. And so we want to go ahead and include the importance of vaccinations and get their input as to what are the barriers. Why do you not want to get vaccines? What will help you understand and disseminate information to others about the importance of vaccines. We also know that patients are more likely to really listen to other patients, sometimes in medical personnel. So our whole program is focused on the patient being the one disseminating the information to other patients, of course, with our guidance as to what type of education to include. So opportunities for COVID patient research, because of all the disparities that we are seeing, every almost funding agency is putting out calls for applications. So the NIH, the PCORI, a lot of private foundations, universities are all soliciting research projects to address these disparities. And they can vary from a wide range of topics. A lot of work is going into looking at socioeconomic factors. How do we get community engagement to help disseminate these informations? How do we get better testing? What are the barriers for that? There's also some genetic components that are being looked at. Long-term effects of COVID. We are hearing now about patients who survived COVID, but now are having other health challenges, mental health, brain health. All of these things are important features that need to be evaluated and studied long-term. Now, lastly, I just wanted to mention telemedicine. I'm anxious to hear if Many of you have had telemedicine visits with your physicians during the COVID pandemic. I want to just mention it here. Certainly, it's been a tool for us to be able to limit exposure of patients. And a lot of our efforts have been how do we reduce COVID exposure. But we also want to make sure that the patients who have not been exposed to COVID, who are properly social distancing, staying at home, that they're not getting sick. All of you have heard that patients have not been going to the emergency room like they should because of fear of COVID. So this is a mechanism by which those people that are not directly impacted by COVID can continue to get health care. And so the Centers for Medicaid Services did release a waiver in March to help address this so that patients, whether COVID or non-COVID, could see a physician either while they're at home, either an office visit. It's also approved for hospital visits to reduce exposure to COVID. Previously, telehealth was only allowed for rural situations where patients were in rural areas and their doctors were remote. But now you can do it right in the city where you are. The dialysis unit is also approved to do telemedicine, as well as the outpatient clinic and the hospital. Why is telemedicine important? It helps to preserve personal protective equipment. It helps to reduce medical staff exposure, as well as the exposure of the patients to healthcare workers. Maximize utilization of the provider workforce and we've seen many nurses, physicians fall ill with COVID. And so it's a way for the other remaining physicians to be able to maximize care and see patients. And it's a way to really communicate with the patients and their families. We use the iPad in the patient's rooms in the hospital, and we can communicate and conference in the family. I think most of us know one of the most tragic things about this pandemic is that patients are alone in their rooms and not being able to have their families with them. And in this way, you could have potential rounds with all of the family members, the physicians, other palliative care, etc., to conduct family meetings. And this can also be done in the dialysis clinics, which we are doing. So in summary, minority populations are at heightened risk for poor outcomes, including COVID-related kidney disease. Strategies to improve health outcomes in vulnerable populations can only be effective in minorities if they're well represented in clinical research activities. And access to telehealth is important to stay healthy in the midst of the COVID pandemic. I have here patients engaged in their own care have better outcomes. And there is no place like home. I think we've all learned that from this pandemic, that we've been able to function from home and adapt our lifestyles, and that we can get a lot done at home, and it's not such a bad place to be, especially when we need to properly social distance. And remember that we're all in this together, and there. For anyone who wants to contact me in the future with any questions or any more information on some of the research activities. And thank you very much.
Thank you so much, Dr. Lee. I know we're going to save questions to the end, but I'm going to put one or two to you right now. Being a nephrologist and a specialist in the endothelium, which you can describe what that is. Recently, there's been a lot of discussion in the literature about increased coagulability, increased blood clotting, and other signature things that come along with COVID. I consulted on a patient in Mississippi a few weeks ago, and she had total organ failure, including renal failure, heart failure, etc. Can you comment on some of those complications as you see them in your population and the literature?
Yes, and I just realized, Randall, you had asked me about vitamin D too. Do you want me to
Yes.
comment on that? Because I didn't get to comment on that. So yes, vitamin D has been, I don't think it's strongly accepted that it's a significant risk factor, but there is some signal that it is, and we all know that African Americans have lower vitamin D levels due to less exposure to the sun, etc. So the literature that's out there is suggesting 10,000 units of vitamin D3 a day, to take that for a few weeks, and then you can drop down to 5,000 units a day. Now, many of the clinical databases, you know, in the beginning when this all started, no one was really thinking about vitamin D, so I can't say we have a lot of data about the vitamin D levels being low in this patient population. I think it's being looked at more now, but if just historically, you know, African Americans are lower in vitamin D, and so it's a good thing to do that, as Randall said, in addition to things like vitamin C. And it's an anti-inflammatory type effect of how it works in preventing the inflammation in the lungs from the coronavirus. With regard to the coagulation issues, yes, there is a lot of work related to that, and we know that there is a hypercoagulable state in these patients, and that they often are pretty much the standard treatment if they measure certain levels. One particular blood test is called D-dimers, and if they're over a certain level, about 3,000, those patients are automatically put on anticoagulation, things like heparin, to thin their blood. I have not found any particular sort of mechanisms or genetics information regarding why this is happening in African Americans, to answer your question, Randall. I think it's something that we're seeing across the board, but again, it seems to be more prevalent in the African American population. But there's a lot more investigation into that at this time. Yes, Dr. Jordan?
So patients who are admitted with diabetes that you've seen, are they admitted with control or out of control diabetes?
Yeah, that is also an important issue that I think we need to address, because it's not really, mostly every time you read something, it just says they have diabetes. My personal experience is not necessarily poorly controlled. It's not, you know, it's not where they're just totally, you know, out of control. I mean, it may be some patients, but it's just really right now, most of the data is just looking at whether you have diabetes or not, whether you have high blood pressure or not really the degree of control. But that is something that I believe we should look at in more detail.
I talked to the doctor who cares for me at a local hospital, and his comments were that they all come in out of control. And I think something we need to make sure of, because a lot of people sort of react like children. They have diabetes, and you know, grandma having a blood sugar of 300 is not considered unsafe, and it is. And you can eat fried pork chops and fried chickens. I love it. I know Randall loves it. He used to love it anyway. But you don't eat too much. And I think it's important for us to control our diet, because this virus, whatever it is, likes sugar.
Mm-hmm. Yeah, I agree.
It's great getting thrown under the bus every now and then, Dr. Jordan. I appreciate that. There's another question I'd like. Years ago, when I was in training, we had the single largest peritoneal dialysis program in the state of New York, but it was 100% white. And the reason was that the doctors at the hospital where I trained at said that blacks weren't hygienic enough to do peritoneal dialysis. And looking at your slide where it showed that we're not using it very much, can you comment on why it's good and what's the reason for such a low number of African Americans using peritoneal and home dialysis?
Yeah, so certainly we believe a major issue is that the African Americans are not even offered or encouraged to do peritoneal dialysis just because of what you just said. There's already bias that they're not cleanly enough, they're not educated enough, don't have enough family support, etc. So we do believe that that's part of that disparity. We at Emory, we have 20% of our population on dialysis is at home, and 80% of those are African American. So we know that it can be done in this population. They have to be encouraged and supported to do it. But there's not any higher risk of, I would say, failure in African Americans who do home dialysis.
Yeah.
But they have to be informed.
Yes, they have to be informed, yes.
Well, doing some informing right now. If I had to go on dialysis versus going to a hemodialysis unit 3 times a week, sitting there in a chair for 4 hours, looking at some boring TV show, I would rather take peritoneal dialysis where I have to see my doctor and nurse once a month. And the rest of the time I do it on my schedule at home. And I can even have a machine given to me, paid for by Medicare, so that when I go to bed at night, I can plug it in. And when I wake up, I can take it off. What do you say about that, doctor?
Oh, definitely. That is when you ask, when patients find out about the options, they are going to most of the time choose the home dialysis. It gives them more liberty to function normally, to travel. They feel better. They have better outcomes. So it's really the more ideal way to do dialysis, but the physicians and the medical team have to encourage them to do it. We also know that the physicians oftentimes may not be home therapies either. So we're also in the process of educating and making sure that all of the physicians are knowledgeable and have adequate nursing staff, et cetera, that can train patients to do home dialysis.
There's another statistic I'd like you to just address before we go to our next speaker. We know that African Americans make up less than 15% of the US population, but there are some figures, and you'll have to correct me on them, that African Americans may make up more than 45% of the population needing transplantation or dialysis of any form in the United States. And that according to the slide that you showed, that of those people on dialysis, some 27% or so are there because of high blood pressure, and maybe as many as 47+% are there because of diabetes. And most diabetics that I know are also hypertensive. Maybe you can comment on that.
Oh, yeah, for sure. I would say probably 90% of people with diabetes have high blood pressure. So I would say probably the majority, that slide just looked at those individually, but I'm sure the contribution to hypertension is much more than the 20-30%, because they both impact the vascular system and predispose to kidney problem. That certainly is one of the major reasons why you see the disparities in kidney disease. And like you said, 15% of the population is African American, but they make up, the latest I saw was maybe 36% of those on dialysis. And for example, in the state of Georgia, 30% of the population is African American, but 60% of the people on dialysis are African American. So it's really almost double their representation. And so it's really interesting that we're seeing the same kind of disparities around COVID and the kidney failure, et cetera.
And I'm going to ask you one more question before we go, and we'll come
Yes.
back. What is CKD and why is it so important? And what relative numbers are there in CKD in the population versus in the population of those on dialysis?
Okay, very important question, because probably the majority of people on this call have some form of chronic kidney disease. So the numbers of people who are on dialysis, we call them CKD stage 5 to 6. In the US, there's about 600,000 patients on dialysis, but there's 20 million people with some stage of chronic kidney disease, and usually within the first 3 stages, stages 1 through 3. So most of, as you age, your GFR, your kidney function declines. So most people probably over the age of 60 are probably CKD stage 3. And then people who have hypertension, diabetes, may not really know that they have a kidney problem or haven't been told that, but they probably have some close to stage 3, which is about between 30 and 60% kidney function. Normal kidney function is around 90 to 100%. People on dialysis, kidney function is down to 10%. The major issue about kidney disease is most often people don't know they have it, they don't have symptoms, and that's why it's important to go to the physician and get your numbers checked. They often don't have symptoms until their function is down to 20 or 15%. So that's a really important point, Randall, I hope people take home today.
Well, thank you so much, Doctor. I appreciate it. I want people to give me a pass for a minute. I am from the old school, and I think I have a special treat for us. I hope that that person is on the line, and I want to precede it. Martin, can you play a little something for us? And we're going to hopefully enjoy something before our next speaker comes. Go ahead. Right to interview, and I hope he's on, is Mr. Eddie Levert, the founder and the OJ singing group. Mr. Levert.
There was a wrong picture there.
Is Eddie Levert on? I don't want you to sing, Dr. Jordan. Hold on.
No, you don't want to hear me sing, I can tell you.
Is John Sudukas available? Unmute, John.
Mr.
Okay.
Levert is there. He's unmuted now, Randall.
Okay, here we go. How are you?
How are you, Mr. Levert? How are you, sir?
How are you? I'm fine. I'm fine. How are you?
Good. Myself and a lot of other people in my age group are similar to you, and we've been big fans, and I was so pleased to speak to you and know that you were going to join our call today, and I'd love you to have a few brief words to our group. We're trying to encourage our people to stay safe and use masks and take care of the people that they love.
I think that's a great idea. And I think all of these other people who don't believe in masks, I guess they feel like they'll be recognized as criminals if they put on a mask. So, which some of them might be, but I think we need to, in order to protect one another and protect the people that we love and the people in my age group, because I just found out this year when we went into quarantine that I was one of the elderly. And I can't, and knowing that, I just think that we need to be just a little bit more caring and protective of our loved ones and the people and friends also.
Well, I certainly appreciate you. And that was my favorite song, Love Train. And this really is about loving our community enough to give them the best information, the best advice that we can to save lives. And that's what our doctors and consultants have been doing. And I appreciate you joining us, Mr. Levert. Any final words?
I want to ask, since we have a lot of doctors on here and a lot of people who are in the medical profession, I just want to ask them, now you got all of these people who are crying that this is a hoax, this is something that was put on by politicians, or this is a man-made virus. Even so, it being a man-made virus, it's still been able to attack people of color, people in my culture. And I want to know just how serious is this pandemic? Is it real, or is this something that people need to take seriously and believe in this and do the due diligence as far as washing your hands and not touching your face and wearing a mask and all of that stuff that they keep talking, and social distancing and all of that stuff? I just want to know, coming from doctors, how serious is this?
It's very serious. If I may respond.
Expound on that a moment, Dr. Jordan.
Well, first, my favorite song that you all was Stairway to Heaven. So this is a very serious situation. And we had a young man last week who went to one of these parties. But 3 weeks ago, he went to the party. He died last week, and he told the nurse before he died that he did something stupid and went. And whether it's man-made or not, it is here. Whether it's man-made or not right now, it doesn't matter. It will kill you if you get too much of it. We have to do what we need to do to make sure we stay alive, period. And there are things that we can do. Certainly social distancing, wearing a mask, washing your hands. You say it over and over and over. Young people too, because they may be the one who get sick, but they have a greater chance if they take it home to grandma after their parents, they can get sick. You get sick more when you are in a closed environment and you breathe in particles over a long period of time. And if you look at in LA, if you look at some of the communities, Castaic is one and Little Armenia is the other, because a lot of their cultural, social things involve being in a small room with 20 people having a lot of fun. And I've been to two of my patients' festivities like that a long time ago, and I had a great time. But this is not a time for that. This is not a time for you to go to some small storefront church and dance. I mean, we go, you do it, you're relieved, but you're in a small place, the air is contained, and you're breathing hard, or someone else is breathing hard, and you're going to end up inhaling a lot of virus. When you inhale a lot, particularly, it gets into your nose, your buccal mucosa in your mouth, and if you're diabetic or you're not controlled, it likes sugar. You just gave it a Christmas party. These are things we can do. There is no reason for you to be out without a mask, without washing your hands, there's no reason now. And don't follow your idiot president's advice. I mean, we have the worst leadership that we could have at a time like this. But we have to, and we have to get the churches and the community to really come together and start talking about these things. Nothing is gained. Now, I remember when I was 16, 17, 18, I didn't think I was going to die. Now all I think about is dying. That's a part of growing. But if you're 16, 17, 18, you want to live to get to be 70 so you can think about it. But don't do something now to ruin your life. We can't say it enough to kids, and we have to find other ways to do it. But people who are out not distancing, I'm sorry, it's just stupid.
Thank you, Dr. Jordan.
Well, how do we get this message to our people? Because I go out and I see a lot of them without masks on. I see them not worrying about social distancing. How do we get them to understand that this is a must, that this is your life that you're playing with?
I'm glad you asked that question. And I've been talking with John Sudokus, who is our mutual friend. And in the near future, we're going to host, we have about 3,000 people on this call because we're streaming live on all the social medias. But we want to get to millions. And John said he would work with you and others like you, Smokey, Howard Hewitt, and a number of other people. And we want to put on an event that will help get the information out with entertainment. And we can further this effort. Right now, we've been doing it sort of on a wing and a prayer. And thank you for participating. And right now, I think I'd rather be on the love train than a stairway to heaven.
Absolutely.
Introduce our next speaker. Thank you, Mr. LeBron. Our next speaker is Dr. Wilbert Jordan, who is professor of medicine at Drew University. He's been my friend and mentor for years and years, and he knows more about infectious diseases and particularly HIV than any physician in the country. And I'd like to introduce Dr. Wilbert Jordan.
Well, thank you. I have to agree, I would prefer to be on the love train than the stairway to heaven. So when that time comes, I hope I'm on the stairway to heaven, not a stairway to hell. So, but thank you all for those good songs. You remain my favorite group right now. This is a very serious problem. And for our generation, the closest thing we can remember is polio. Now, if you can talk to grandma or grandpa, the early days of polio before the vaccine was a lot like this, because we could be sitting here talking and wake up tomorrow morning paralyzed. So we've gone through this before. The Spanish flu of 1918 was, of course, the worst that come to this, and we didn't have the resources then that we have now. So we have more resources. And I think we have to, and I underscore the word we, have to do the things to get to our community and talk to them. In most places, it involves more blacks than whites. Interesting, because I treat HIV patients at our clinic. We've only had 2 patients come down with it, and we're testing everyone. We've had several who now have antibodies to it, which means they have been exposed, but they was asymptomatic. And I'm starting to think that maybe the HIV meds may be offering some protection. You know, the initial treatments that they did in China was with an old HIV med. And I think that's something we need to be looking at. And again, the summertime is a time to do it. Diabetes is important, and we need to try to get it controlled. The most important for everybody listening, you need to have a physician. Stop the habit of running to the emergency room when you sneeze. Stop the habit of going to urgent care when you have a problem. Have a physician that knows what's going on. Too many of our patients still do not have a private physician. And in this county particularly, you can go to someone. but people don't. They still run to the emergency room, and you need to be going to the emergency room. Now, this past week at Oasis, we treated 7 people with STDs. And I went and asked one, and okay, you practicing social distancing? He said, yes. I said, so explain to me how you got an STD in your mouth practicing social distancing. He looked at me and laughed. This is serious. But I think we have to, as providers, also be comfortable talking to people, to ask them things, to be comfortable ourselves. You know, we've talked about years and many doctors, black and white, are uncomfortable doing sexual histories, talking about sex. We need to encourage people to go get a doctor, but we also need to be comfortable in asking the questions that we need to ask. We have patients that always says, we're still having sex orgies. Why y'all having a sex orgy in the middle of a pandemic? I'm not against sex orgies, but not now. Come on, I mean, we have to feel comfortable in treating patients and on their level, saying things that they're comfortable with. So I can't enough to get people to go and find a physician rather than continually using the emergency room as their place to go. Too many people in our community still do that. I still think we need to, as a people, look at the schools and whether we can, and the churches, and whether we can do something. Most inner city kids, and we've asked our patients, 32% of our male patients have children. So even though they supposedly have men having sex with men, some kind of way they mistook a woman, I guess, for a man. So we have plenty of that. When we ask them, I don't have one patient whose child has a private room. So on the one hand, I think it's safer for a kid to be at home if she has a laptop to be able to study, and 2, if they have their own room. It's kind of hard if you got to share your room with 3 or 4 other people. And it's even harder if you don't have your own laptop. Again, I think this summer, we need to do what we need to do to make sure those kids have their laptop. But all these churches with all these basements and big unused space, let's ask, is there a way we can incorporate some of that and allow these kids to be able to have the space they need, to have the learning experience they need? Because on the other hand, if we don't, and if it isn't done correctly, it's going to hurt our kids more than the kids in Beverly Hills. And I think we have to understand that and be really conscious of that. So that's something I'm really concerned about, and Randall knows I want to work with his pastor and some others and looking at whether there's anything we can do with that. We need to be also involved in clinical trials, making sure it works. I'm a believer in the vaccine, but I want to make sure the vaccine works. So I don't want anyone coming and telling me this. I want to know how this works. This is a very controlled, very strange entity. I'm not even sure I want to call it a virus because it's not really living. It's a chemical that when it's exposed, particularly to sugar and other things in your system, it becomes activated and it goes wild. So we need to understand that. So I'm happy to see that someone at NIH that I can talk to. I think we have to do those things as well. If there are people who need food, again, this is the summertime, we need to help them store things. So you don't end up going in the store in November and there's nothing there, because this girl is coming back, I think, in late November, early December, and we will have another round of it. But this time, we have to do things to make sure that we're better prepared than our leadership has done this previous time. Thank you.
Thank you, Dr. Jordan. I'd like to ask you a few questions before we go to the audience for questions. I know you don't have a crystal ball in front of you. Actually, you may. But
I have my dad's crystal ball.
What is it that we can expect going forward with all of the spike that's going on in California and Texas and Florida. And in California, we did a lot of things right, I think, but it still came back. Are we looking forward to a 2-week period of quarantine? Are we going to need to social distance and quarantine further in the near? What's going on in the future?
I think, and this is my opinion, social distancing, wearing masks, washing your hands, etc., is a new norm that will be with us at least through 2021, period. Certainly in November, December. I thought the summer, this virus would go down some, but other events and people coming out too soon, we've got new spikes, etc. And I think because of that, it's going to be at a higher level than I had hoped that we would see in the summertime. It's July now. I was hoping, just like the flu, July, August, September, it's sort of quiet and it starts raising its head again in October. People just couldn't stay in, and the things we're doing is hurting. And I think, so we're keeping it at a higher level in the summer than it could have been if we practiced better social distancing and wearing masks, etc. And because of that, we're going to start off in November at a higher level. Fauci may have been fired or not, but he knows what he's talking about. And people better listen. And the least thing you want to do is listen to who right now is controlling the White House. They don't know anything about anything, period. And I thought when Goldwater lost to Johnson that was the end of this era. I didn't expect it to hop back up at my age now, and it's sort of like we're experiencing now what would have happened had Goldwater won. This is very serious, but there are things we have to do, but we don't have a choice. Either we do it and live, or we don't do it, and Andrew's funeral home is going to be very happy, but that's our choice.
What are some of the clinical treatments coming down the thing? I know we've talked about remdesivir, shortening hospitalization. There have been recent articles about using methylprednisone and other things to inhibit inflammation. What are some of the clinical things that you...
First thing, if I were to get sick, I'm going to go to a hospital where they have experienced people treating me. I'm not going to Podunk Community Hospital. This is a very, very, very serious thing, first of all. I may hop on the plane and go to Emory to see Dr. Lee, but I'm not going to some hospital 25 miles north of Atlanta. And that's my arrogance. One, I think we're getting this mixed up with hydroxychloroquine. I think that if you read the data that's been published objectively, it doesn't say very much. There are some other data out there that they're pushing it. I have a friend who runs a clinic in El Centro, California, and he uses it. The doxycycline and azithromycin in the early stages may offer some protection. I don't know. Both of those antibiotics are bacterial static, meaning they don't kill the bacteria. They basically freeze it and allows your white cells to do it. So in an early situation where you think you may have been exposed the first 5 days, if someone takes it, it may offer some benefit. I think we don't have anything yet to really look at it. This is what I'm hoping we can do in the summer, trying to profile things to see which regimen better. I am still impressed with my HIV patients. None have been sick. We've got, I think, 5 who have had antibody tests that's positive. They were asymptomatic totally. They didn't know they had it. We know of 2 who had it. They stayed at home. They never got sick. And I think, looking at that, I think the antiretroviral medicine may be, again, it's an RNA virus, so some of that may be contributing. This is early, and we still don't know. And I think these are the things we have to start looking at, and I'm hoping we could really do it in the summer when we had time off, rather than people still having to devote so much energy to treating people. That's what's really bad about this. But I'm hoping before November, we will have some better idea of something that we can use. Certainly, if you make antibody, gamma globulin that we've always used, but it looks like the antibodies to this don't last very long. Some patients, it looks like it doesn't last 6 months. So if I can get your antibody, if you've had it and you're stable and get you to get antibody, we can make an antibody we can give to someone else. The question there is, do we give it to someone who is very sick, or do we give it to someone who is early needing to be hospitalized or can stay at home and get it? I mean, those are the things we need. I don't think we have that much antibodies to give to everyone. So we're still limited in terms of things we need to do. And this is where being organized and trying to do things in the summer will help. I mean, that's what I'm working with one company to sort of see if we can do something like that. But it's still early. So a lot of things that we need to know, we don't know. I just don't want people using money on quacks and running for folks who claim to have a cure and spending your money. We went through that with AIDS, and we had a lot of people spend a lot of money on folks who claimed to have had cures, and all they did was come to us late and they did. If there is a cure, if someone has something promising, one, you can be sure that this program, we will advertise it to the rooftop, but it will be everywhere else too. You're not going to find some place with a cure in the south part of Crenshaw and no one else knows about it. I mean, people have those needs, but you're just wasting your money when you do those things. We have to make sure people trust us. And a lot of people, for some reason, still don't trust us. And you need to either, if you believe in God, either we're instruments of God or instruments of the devil. Now, if you think I'm an instrument of the devil, you should be running like hell to get away from me. But if you think I'm an instrument of God, or you're an instrument of God, then trust you. And I think a lot of our own people don't trust us as much. And I think this is a time that we have to really call people, get people to do things like that. Thanks.
One more question before we open the floor, and that is, and I'm going to put this to you, but Dr. Lee can also answer it. There was a question about being in a building with air conditioning where people are positive. Does this virus have the potential to get into the air conditioning and be spread more, or is that not true?
Well, to me, you're asking two questions. Right now, we're in a building with an air conditioning, and there's someone in the building who has the virus, and he or she is spreading it in the air. The air is, we feel the cool air, etc. So can any of us in this room breathe it in? If the room is 20 by 20 versus if it's 100 by 100, if it's 20 by 20, certainly we can breathe it in. There's a good chance we will breathe. Some of us will breathe it in. If it's 100 by 100, those standing or far away may not, etc. Now, we come back to the room 2 days from now. Is it in the air conditioning system itself? No one has tested that. If you're going to ask me, I think it probably is. I don't know what the half-life of it is, but I think that is a possibility that if someone was there and they got in the air conditioning system, it could still stay. Now, the other side of that, of course, if we have a reverse airflow, then you shift the air out and you don't have that problem. But most offices, most places that we function do not have that kind of system. So he would like to lead things about that since she's treating patients.
Dr. Lee, you have a thought on that?
Yeah, no, actually, I agree with everything Dr. Jordan said. I don't have any particular experiences. I know that I've heard about the different filtration systems, and certainly most hospitals are adequately protected in that regard, but certainly I agree that homes and smaller businesses, certainly I would not assume that the virus is not there. So I agree with that.
So I have a question for you and Dr. Jordan. I actually have two. Are there any questions first in the chat box, Judy?
We do have a question, several questions that were answered by Dr. Ann in the about vaccines, so I could summarize that for you.
Go ahead.
Okay, the question was asked about vaccines, and basically she asked that the first vaccine may not be the best or the most safe or effective, and there's a group at Oxford that has a head start on developing a coronavirus vaccine. They said that yes, there may be more than one, and also that we need to be in position to put indeed pressure to get the safest and most effective for our populations. We will need to review the data for African Americans. And then it also said that the only way to anticipate possible genetic factors is to be included in the trials. And then there's another question, how would we grow clinical trial participation? And also there was a question about Operation Warp Speed, which is a vaccine program, if someone could address that.
Okay, Dr.
Well, if we remember the polio vaccine, the first one was a Salk. And then we learned that Sabin was better. It was easier. You'd have to take a shot. It was more effective. So the first vaccine may not be the very best vaccine. I think it's important for us to participate, not so much to know whether it's going to work in blacks versus whites. It should work in everyone in terms of our immune systems are really the same, other than unless there's some reason it lacks blood type A more than blood type O. But I think we need to develop the whole habit of we want to sit at the table. We have marched, got our asses kicked, beat, everything to get at the table. Now we have a chance to be there. Let's sit and be a part of the planning to make sure that we are able to make the decisions too. No one else is sitting there making the decisions for us. Everybody else is making the decisions for themselves. We had to learn up that AIDS commission. People would go and fight over things, and then afterwards, here come some of the blacks complain no one had done anything for them. Get your butts here too. We have to be there. We just can't wait for the master to talk to us and feed us. We got to feed ourselves. We are men now. We're not boys anymore. So we have to be there. And I think that's important in terms of the attitude. So much of this, I think, makes us have to develop mature attitude about these things. You don't go in screaming and hollering, but we go in wanting to make sure and look at the data.
Thank you. If Dr. Gibson's on, I have a question for you. In the meantime, I'm going to ask Dr. Lee and Dr. Jordan, given the apparent presence of hypercoagulability that is being seen in some pathological specimens, is there anything in the literature that speaks to the fact that we may need to consider anticoagulant therapy? And would that depend upon whether this is directly in the cells of the endothelium versus a real coagulopathy or abnormal clotting mechanism?
Yeah, well, I mentioned earlier that, since the onset of COVID, and we have learned a lot about the patients and the characteristics and risk factors. And so it became very clear that there was increased risk of thromboembolism, et cetera. And one of the tests that they use to look at that is something called D-dimers. And so they found that if it's over 3,000, those patients are at most highest risk. So those patients, when they come in, they're automatically being started on anticoagulation now. And so even though we're still seeing a lot of cases, the actual death rate has declined, as a result of those types of therapies, of addressing that before it becomes a problem. So yes, definitely there's more emphasis on that, and there is targeted treatment earlier than we were in the beginning when this first started.
Thank you. Is Dr. Gibson on? Is Dr. Gibson on? Can you unmute yourself? The question that I was going to put to Dr. Gibson, who is a PharmD, is that we know that all these vaccines are being developed. And is there a way that we can vet or look at some of these pharmaceutical companies in terms of their track record? How can we be at that table, even though some of us are professionals, some of us are community people? How can we decide that a vaccine developed by company A is more efficacious than company B? Is there any way that we as regular people can do that, or we're going to have to go through our organizations, the NMA, the AMA, the Black Health Trust? I'm concerned about some of that. Your thoughts on that, Dr. Jordan and Dr. Lee?
I would go with the NMA. Now, not anyone from the NMA, but I think that has a national standing. Most of these companies certainly either know about the NMA, or if they develop something, they're going to want to work with the NMA. And any company that is working, they should ask to have some, whether it's ex officio or not level, but someone should be there to be able to look at the science and be able to say yeah or nay, et cetera. It makes sense. But I think the NMA is the ideal organization for doing that. And I think we need to be there, not someone from the AMA that's Black, that's a difference, but someone from a Black medical organization to do that.
Well, thank you. There are some previous medical colleagues and speakers that I invited back, and I wonder if any of our previous physician speakers would care to make a brief comment on the topic. Is Dr. Bailey on? Dr. Richard Williams? Dr. Randy Hawkins? Anybody that's been on the call before as a speaker? I can't see everybody's name. Judy, are there any other questions in the chat box? Judy, there was a question about vitamin D. I can't hear you. Are you muted, Judy?
Yes, she is.
Can you unmute? Okay. Very good. Are there any other questions for the chat box? I'd like anybody, I'm inviting you to comment, but do it in the chat box and we will recognize you. Okay. Well, first of all, I want to thank our excellent speakers, Dr. Stavern, Dr. Lee, Dr. Jordan, and our special guest, Mr. Levert. I'm going to do a quick round robin and ask Dr. Lee, does she have any final comments or words?
Okay.
Dr. Lee? Do you have any final comments you'd like to make?
Randall, this is Judy. I finally got unmuted. We do have a question for Dr. Lee about recommending a vitamin mineral daily regimen.
I think she's muted. I think you need to unmute Dr. Lee.
There's a problem with the mute button.
Down in the lower left-hand corner, there's a microphone.
Okay, I'm here. Can you hear me?
Yes.
Okay, so yeah, with the vitamin D, it's recommended to take 10,000 units a day for a few weeks, and then you can reduce it to 5,000 units a day. You know, there's some hint that there is an association with vitamin D. I don't think the evidence is very strong, but we do know African Americans are more likely to be vitamin deficient. So I would suggest taking those doses. If you've been able to measure your vitamin D, then you'll know for sure you want the level to be around 30 to 40 to be adequately treated and have an adequate level of vitamin D. For patients who have kidney disease, they usually are more vitamin D deficient and need doses closer to 50,000 units per week. Um, um, and that can be for several months because of their extreme vitamin D deficiency.
I think any final words you want to say before we?
Oh, yeah. Again, I hope that we've heard a lot of information, and I just hope that everyone takes this seriously. It is a real problem in our community, and certainly with the population has. I see it continuing to be a problem, and so I want to reiterate what was said earlier by Dr. Jordan about making sure patients are getting to their physicians, because if you don't go to the doctor, you don't know that you're at risk and you don't take proper precautions. So those are my closing comments. Randall?
Very good.
Thank you.
Excuse me, Dr. Maxey, this is Lamont Gibson, a pharmacist. Earlier, you invited me to add comments, if you will, to Dr. Lee's discussion on dimers and other issues of importance with people that have hypercoagulability, for instance. Since so many patients that receive treatment, particularly for renal conditions, as well as cardiac conditions, it's extremely important that patients be monitored if they happen to be on specific antihypertensives like ARBs and ACE inhibitors. Very, very important.
Well, thank you very much.
Dr. Maxey?
Is that Dr. Motley?
Yes, it is. I have a few brief comments.
Okay, first I have to introduce you, Dr. Motley.
Okay.
Dr. Motley happens to be my friend and neighbor. His nickname to me is Dr. Einstein. He is an MD. He is a PhD in electrical engineering. And he has spent a major part of his career working in the aerospace industry, Department of Defense, and with artificial intelligence. So I'd like to introduce Dr. Einstein.
He's done it again. No, I had a few comments about the vaccine development that seems to be pushed to the side. There's over 100 different teams trying to develop a vaccine for the COVID. But the one thing that there seem to be missing is we need to have a treatment to complement the development of the vaccine. If you give a clinical trials patient the vaccine and then expose them to the virus and not have a treatment, you can run the risk of killing them. So you really need also to concentrate on the treatment as intensely as they're concentrating on developing the viruses. I'll just, one more brief thing about the trio of us. Dr. Williams, Dr. Maxey, and I are currently looking at a treatment for COVID. It's a very novel treatment, and I won't get into it at this point. Maybe at a later date, we'll give a presentation on what it is. But we need a treatment to complement the vaccine development, or you run the risk of really violating medical ethics. You're giving somebody a vaccine and then exposing them to the virus, and you may very well kill them. So that's just what I wanted to, one thing else. I've been asked this question a dozen times recently. Why do we need to limit the number of participants in any kind of gathering of less than 10 or less than 5 or whatever the number is? It's all got to do with viral load. These kids don't understand that the more people they're around that may have the infection, the viral load that you receive is larger. And then ACE2 receptors just get hit so hard until the stuff spreads quickly. That's about all I had to say. I'm off.
Okay, I'm going to put another question to the group here before I ask Dr. Jordan for final words, and that is, we know that some of the pathology, some of the pathophysiology, especially of the ARDS, the acute respiratory distress syndrome, is related to a hyperimmune response. So in many cases, our immune system is responding, but it's responding so well that it creates a problem. And that may be where the use of methylprednisolone comes in. I'm wondering if one of the speakers would comment on that, whether it be Dr. Lee, Dr. Jordan, Dr. Motley, or Dr. Gibson, or if any of my other colleagues are.
I agree with that. I think what Dr. Motley said, I think is very important. In those situations, you need methylprednisolone or something, and that's where I think it's important for the patient to go to a hospital where the clinician recognizes that. And you know, I hate to sound arrogant, but I wouldn't want to go to Pam Dam Community Hospital 100 miles north of Los Angeles if I had it. But I think the point that he raised earlier, something I said at a previous meeting, I think we have to emphasize and focus as much on treatment, because he's right. If you vaccinate, you offer a vaccination to people and it doesn't work, and you give them or expose them to COVID, what have you done? So I think we have to do both. We can't abandon treatment strategies. And what we have now is not the state of the art. So we need better treatment strategies as well as to be emphasizing vaccine. I mean, the press has made us sort of look for a vaccine. As a different than a vaccine from when we had measles. If you have measles, you become immune to measles. So giving you a measles vaccine is simply giving you up front something that you would already have. This is very different. And that's why we've never had a vaccine for gonorrhea. We've been dealing with. There's a whole different thing that's happening when I give your body something that's going to now make your body do something that it cannot normally do. And I think we have to understand that, which is why, again, I say the NMA, we need to have people present to understand the science of this.
Well, thank you.
Dr. Maxey, this is Lamont Gibson again. Forgive me for interrupting. There has been quite a bit of a discussion of the use of dexamethasone as a corticosteroid that's proven to be useful in helping patients that are critically ill with this condition. So proper positioning of these patients face down, along with dexamethasone, has shown some promise in addressing the cytokine storm that you mentioned earlier.
Very good. I want to introduce somebody who joined the call. He's professor of medicine at UCLA. He was named one of the top 15 academic professors in the country. And I understand, he didn't tell me, but he is now vice president of UCLA College of Medicine. Dr. Keith Norris, I know I'm catching you, but I need you to comment.
Yeah, so that's a little, thank you, that's above and beyond. That's not what I do. So I'm, where is it here? So the Department of Medicine at UCLA has, let's get this background here, as a new office for equity, diversity, inclusion. So I'm the executive vice chair for that office. But I took the position because I was able to negotiate a better package for my office than the dean's office has, or I think the vice chancellor's office has. So,
Now,
so
he's also a kidney doctor like Dr. Lee.
right, so I wanted to make sure that if we were to do it, we had the resources, and we had the resources to do it, the work that needs to be done.
Thank you, Dr. Norris.
So, no, it's just been great listening in and listening, hearing what everybody had to say. It's always informative and good to learn something. So I've just been sitting back, listening and listening to the watching the chat and listening to the conversation. So thank you for having me.
Good to see you.
Good to see everybody. You're welcome.
Very good.
Cecil.
So, very good. This is a bit of a social call. So I teased Dr. Jordan for being the person who interviewed me when I was going for my internship. I introduced Dr. Lee as looking like a award-winning singer, Alicia Keys. Now I'm going to tell him your secret name is Doogie Howser. Okay. Dr. Jordan, I'm recognizing you for some final words, if you have any.
Just thank you for doing this, and I hope you will do it again. I think we need to do this more and be able to reach out to the community more. This is our responsibility if we're going to see the number of cases in the Black community fall. We need to be doing these things integrated with the churches and other organizations. So you have I'm glad you're doing this, and thank you so much.
Thank you. We've got just a few minutes. I want to have a brief word about what we're trying to do. We're trying to, every week, same time, we put on this call, and it's our attempt to bring credible information to communities of color. And we've had an outstanding group of physicians and healthcare providers make presentations about their views and opinions, which I respect very highly, on how we should be sure we're safe, what we need to do. We're trying to present information on a level that everybody can understand. We're not doing it like we do on rounds, but doing it like we do with our patients. And at some level, we're all patients. I have learned after doing this for the past several months that we have grown from seeing 30 or 40 people on the Zoom part of the call, that we have reached as many as 3,000 people on each of these calls, because we are streaming this on Instagram, Facebook, and whatever else is out there. So I don't know how many we've reached today, but I believe we will probably be over 3,000. It is also our intent to have a newsletter out every few weeks, if not weekly, to have a blog, and to have, we have a website up already, and all the previous talks that have been given, as will this one, will be on the website that you can look at past information. And we hope to have a way that you can ask questions and we can respond to them. We've retained a virtual assistant who is helping us answer this correspondence. We have a marketing team that helps us with our media development. And we have a CPA, an accountant. We have other helpers. And we are a not-for-profit. We are right now trying to raise $25,000 to carry us into the point where we can have a grant writer help us get something to sustain this program. We have an idea that we can spread the word amongst our community, where we're seeing a few thousand people every week. I think this information is valuable. To that end, many of you got a letter from me a week ago soliciting that we'd love you to be a member for $500, but if you've only got $10, that would be good to us. It will be tax deductible. And if you got $1 million, don't hesitate. We'll take that too. But there are some costs going along. We have a steering committee, and many of them have come out of their pockets to sustain us so far. But join us if you would. We also know that many of our people don't have trust, and when they're not working, that people can take their assets in their homes. Many of us get pulled over by cops and law enforcement and don't have money to pay a lawyer, so we have created a relationship with Legal Shield, where that we can make services available to people through that, and the Black Health Trust will get part of that money. In addition, I signed a contract a week ago with a company called Second Opinion Expert, and we're creating a platform where the doctors on this call and others, well-known physicians, professors, can answer your questions in consultation. There will be a small fee, or maybe they can charge your insurance, but this proprietary software can upload and redact and summarize your medical records so that the doctor himself only needs a 20-minute review and has access to all of your imaging and laboratory, et cetera. So that will be a service, and we hope to have that up by the 1st of next month. So we're doing all we can to give doctors to the Black community so we can back you up. My saying is, nobody cares how much you know until they know how much you care. And so hopefully you will join us. If you have ideas, you can contact us. We do have a website you can contact us through, and it's called blackhealthtrust.org. And on that, our consultants have put the CDC information where you can look at daily totals of disease. There's a wealth of information on there about protecting yourself and your family. And I thank all of you for joining us. If there are no other questions, no other items, is Ms. Brenda Leon? Well, all of us may have different spiritual beliefs, etc. I happen to be a Christian, but I believe in God Almighty, and I pray for His blessings on all of us and our families and for protection. And again, thanks to our speakers and guests for today, and thank you, Mr. Levert. Have a good day, everybody.
God bless everyone. I just got unmuted.
Okay, go ahead.
Okay. I like to start with just taking a breath. We've heard so much wonderful information today, and some of it is a little bit overwhelming for me, to tell you the truth. But I like to take a breath because it brings me back to my center, brings me back to the middle of my heart where God rests and resides. So I'll take a breath if you'll take one with me. I know that there's one life, and that life is God. It is our life. We're living and moving and having our being in this one life. We're all beautiful cells made up in this wonderful thing that we call God. And Father, I thank you for this panel, these people on this call, these brothers and sisters who are knowledgeable in things that we're not, but we're trusting our doctors. We're knowing that what they know, they're imparting with us. I'm learning more about life and the doctors than I've ever had in my whole 72 years. So I give thanks for each and every one of the people on this call. We're in this thing together, as Dr. Leah said. So I bless this day and every day. I bless our families near and far, surrounding us with the love and light of God, knowing that the presence of God is watching over us wherever we are, because wherever we are, God is. And I rest assured in that, and bless everybody until we see each other next week. God bless you. So it is. Amen. 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 Thank you. Thank you.
Thank you, Ms. Brenda. Have a good day, everyone.
You're quite welcome.